Thank you. I think I'll. Oh, okay. Okay. And do I click it to myself? Or just hold on? Okay.
And yes, put in the pocket.
Is it on?
Yes, sir.
All right. Okay. Okay. I'll just wait a couple more minutes. I thought this was supposed to be full, so. And just, for those of you who came yesterday, when I looked at the attendee list, there were way more non-2-day people than 2-day people. So this is basically the same lecture as yesterday, just with a different example. So I recognize you from yesterday. So there will be some, other options and issues we'll consider that are relevant to this case study, but it will be very similar to the talk I gave yesterday. So dynamic IPW is going on now, right now. So that was a mistake. Yeah. So you go to that lecture. That'll be good for you. You should learn both. Okay. All right, I'm going to get started. My name is Jessica Young, and this is a workshop on the parametric G formula as implemented in SAS. The structure of the workshop will be, basically we'll be breaking this up into two parts. In the first half, we'll be motivating this method, why we would use it in practice, for what types of causal effects, and under what assumptions is it validated. And then we'll go through the general computational algorithm agnostic to a given software package that could be programmed, if you prefer R to SAS or Stata to SAS or whatever you like. I'll explain how the algorithm works, and then in the second part, I'll review how to implement this using the G-formula SAS macro, which is meant to provide a little more of a user interface so that you don't need to program this yourself if you're a SAS user. I'll go through the structure of the macro, the specific input data set requirements, some of the basic features, and we'll review some sample code together. Whoops. What happened? Oh, okay. So just to give a little background, this macro started out as a collaboration of researchers at the Harvard School of Public Health, largely for our own internal use, and over time we've added a lot of features to it and wrote up some documentation and shared it on the web, and have made it available to the public if they can use it for their own research. The version that's on the web right now is version 2.0. The version I've shared with you via Dropbox, and the one we'll be illustrating today, is a new version, version 3.0. That should be up on the web in early April. The documentation for this is not finalized. I shared a draft version with you guys that should still be useful for implementing it, but the final version hopefully will also be up there in early April. So this is where you can access the latest version of the latest version we make public. And this is my email. If after the workshop you have any questions about the material, whether it's the macro or just some of the conceptual issues, feel free to get in touch. I'd be happy to hear from you. So as you know, the structure of this conference, each day we focus on a case study. So today we're motivated by a paper from 2011 in Statistics and Biosciences. In this paper, our question was generally, we were interested in estimating the causal effect of following different combined antiretroviral treatment initiation strategies on 5-year mortality risk in an HIV-infected population, I should clarify, who are treatment naive at a particular point in at a baseline time. Okay, so before we go any further, this is a conference on causal inference, and we should be clear about what we really mean by a population causal effect. What do we mean by a causal effect on risk? By this we mean contrast and counterfactual outcome distributions, say means or risks, associated with implementing different treatment strategies. So we could more formally state the question on the previous slide is what would happen to the population 5-year mortality risk in this HIV-infected population who we're looking at some baseline time if, possibly contrary to fact, we implemented one rule in this population for initiating treatment versus if we went back in time, initiated a different and implemented a different rule for initiating treatment. So specifically, we were interested in the causal 5-year risk ratio or risk difference, some contrast in risk, comparing specific dynamic strategies of this form. So we were interested in comparing dynamic strategies where the rule is start treatment within M months of CD4 cell count first dropping below some cutoff measured in cells per cubic millimeter, or diagnosis of AIDS, whichever happens first. And our comparison is for different cutoffs X. So we could consider this strategy for X equals 500. That would be when your CD4 is still very high, you're still healthy. Start treatment early, or we could wait to start treatment until your CD4 potentially drops as low as 200. So this is basically a decision rule about when to start treatment. And we can think of M here as a grace period. So in our analysis, we defined M as 6. So the idea was start CART within 6 months of this condition occurring. So we'll give you a little time once this condition occurs to start treatment. But the rule says that at the end of that 6-month period, you have to start if you haven't already started. So we can also just think about the simple special case where M equals 0, just to keep a more simple rule in our head, no grace period. So then the rule just becomes start CART as soon as CD4 first drops below this cutoff X, or there's a diagnosis of AIDS, whichever comes first. So these strategies indexed by these different cutoffs are examples of time-varying dynamic treatment strategies. And by dynamic, we mean treatment rules under which the treatment assignment at any time during the follow-up, whether or not you've initiated CART, and say in any month, by any month K following baseline, is determined by evolving characteristics of the patient after baseline. So these, and in this case, CD4 cell count and your AIDS status. So at baseline, under a dynamic treatment rule, I don't know what treatment you're going to be getting, say 6 months later, because it will depend on what's evolving for you over time. This is in contrast to static treatment rules, where the treatment assignment for all subjects is known at the start of the study under that rule. I know exactly how I'm going to assign treatment for you at all times over the follow-up under a static rule. An example would be never treat with this drug. I know that no one will be getting the treatment at any time during the follow-up. Again, a couple of people came in late. I recognize some cases from yesterday. This is going to be a very similar session to yesterday, just a different example. So the first half will seem quite similar, but the second half will actually be a bit different. We'll be going over some different features of the macro, so it still might be useful. So we now understand what question we're interested in answering. How would we answer this if we could? What study design would we run? And if we could, of course, we would run an ideal randomized controlled trial, where what we mean by this is we would take an HIV-infected population at some point in time. We'd have some eligibility criteria that would define that population. Then at some point in time, we would flip a coin, and we would randomize some to follow X equals 200, some X equals 250, 300, 350, maybe 500. Whatever arm these folks were originally randomized to, we would make sure that they are only starting treatment according to the rule that they were assigned to. So there would be full compliance of the protocol until death or the end of the 5-year follow-up. So if you were randomized to start CART when CD4 first drops below 350, and let's say I start with a population of treatment-naive individuals who all up to that point had CD4 above 500, so I randomize one to start when X first drops below 350. That person should not be starting, and they're complying. They're not going to start treatment until their CD4 first drops below 350. If it never drops below 350, they will never start. And if they continue to have CD4 above 350 and then they die, they've been complying up to the time that we observe the outcome. This ideal RCT also would have no censoring, and I put that in quotes because there are many ways we could define a censoring event. A ubiquitous censoring event would simply be they drop out of the study. We could all agree that the subject is censored, and if I don't know what happened to them after they dropped out, I don't know if they died or they didn't die, clearly that's a censoring event. But there may be other events that we might define as censoring events that actually could slightly modify our question, and as we'll talk about in our analysis, we define a censoring event as going 12 consecutive months without coming in for a lab visit. Once you had 12 consecutive months of not being monitored, we censored you. So effectively, that modifies our question a little bit to be what would be the effect of these different strategies in a world where we could eliminate this type of censoring. In other words, everybody gets monitored at least every 12 months. So with that definition of censoring, our ideal RCT would be forcing people also to come into the clinic at least every 12 months and get lab measurements done. So why is this an ideal RCT? Well, by design, there's no confounding. In other words, the reasons that some subjects are starting early or some are starting late are not because they're sicker or healthier, it's because we're forcing them to do it. We're just picking them at random and forcing them to follow a particular strategy. There's also no selection bias by the fact that we've somehow eliminated censoring by our definition of censoring. And in this case, because of the absence of these sources of bias by the design of the study, I can get an unbiased estimate of my, say, risk ratio, causal risk ratio, comparing, say, X equals 500 versus 200, those strategies. And I can do it using a very simple statistic, just a contrast in proportions. For that example, if I wanted to compare the strategies X equals 500, X equals 200, those are my two treatment arms, and I had perfect compliance and no censoring, then what is my statistic that will be an unbiased estimate for this causal effect? I'm just going to count the number who are randomized to arm 1, and then that's my denominator. My numerator is just the number who died by the end of 5 years. The second proportion, number randomized to arm 2, say X equals 200, that's my denominator. Numerator, I just count the number who sometime in the course of the 5 years died of any cause. So very simple as well to compute. Of course, ideal RCTs are almost never feasible. Even when we can run an RCT, we can't force people to comply with the protocol. There's typically some form of censoring. They're too costly. We may not be able to wait 5 years for an answer. Of course, forcing people to do anything, even in this context of a straightforward drug treatment, is unethical. So the alternative is observational studies where, in fact, we can actually think of real RCTs where there is noncompliance and censoring, in effect, as observational studies with respect to the question of understanding the causal effect of actually following these strategies throughout, in other words, full compliance. So, interestingly, this is one of those rare situations. Usually, when I give these talks, I say, well, there was no RCT to answer this question, and so we had to use observational data. At the time we published this paper, there was no RCT, but in fact, a couple of years later, there was a randomized control trial that, in fact, showed that it is definitely better to start as early as possible on antiretroviral therapy. So we're going to pretend we're back in 2011 and there's no RCT. And in fact, in this particular case, our results were consistent with the RCT. There's never a promise of that with observational data, but we were lucky that time. We'll pretend we're in 2011. There's no RCT to answer this question, ideal or otherwise. And so what we did at the time was use observational data from the HIV causal collaboration to try and estimate this causal effect of interest, which we certainly could understand how to design a trial for. Now we need to figure out, and we saw that the statistics in that case are quite simple. We can do inference based on the back of a textbook written several decades ago, but now we have observational data, so how do we answer this question? So just very briefly about the HIV causal collaboration, this included several cohort studies from 5 European countries and the U.S. The cohorts were assembled prospectively and based on data collected for clinical purposes. So it had whether someone had a measurement at each time, CD4 cell count, viral load, and whether or not the subject died, whether there was a diagnosis of AIDS, and other baseline demographic characteristics. Okay, so for this analysis, we sort of imagined that trial that we would want to run in defining the eligibility criteria. Who is the study population? Who would we randomize to these strategies if we could run a trial? So the eligibility criteria prior to baseline, and I'll define baseline in a moment, were people who were available on this clinical cohort between 1996 and 2009. They had no history of a CD4 cell count less than 500 prior to baseline, 18 years or older, not pregnant, and a CD4 cell count and viral load measurement within 6 months of each other at the time of baseline, where we defined baseline as the first month after meeting all of those eligibility criteria. That CD4 cell count dropped into the range, 200 to 499. So basically, again, we can think of that eligibility criteria as who would we recruit for this trial we want to run? People who are 18 years or older, they can't be pregnant, they have to have had no history of a CD4 below 500. Now, we're going to enroll them in the trial, and the first time their CD4 drops just anywhere in that range, 200 to 499, I'm going to randomize them to one of those strategies X. So this is the time, that's their start of follow-up, their baseline. And then subsequently, we broke follow-up time into months. So we have measurements of did they initiate treatment at this time. So this is an observational study. We're not intervening, we're not randomizing, we're just observing, do they initiate treatment in month 1, month 2, month 3, what was their CD4 cell count in each of those months. In some cases there might have been more than one and we took one measurement. We could have broken follow-up time into days because for some people you might have multiple measurements per month, but for computational purposes of when we talk about the algorithm, the reason was just this becomes a very enormous data set for 5-year follow-up and we break time into days as opposed to months. And we do have censoring events here in the sense that we actually know the mortality status for everyone because we were able to obtain this by a death record. But we decided that we wanted to censor people when they had a 12 consecutive months without being monitored, without viral load or CD4 cell count. So as I said, that slightly modifies the question, and we're basically implicitly considering these effects had we also intervened in every arm and forced everybody to be monitored at least every 12 months. And pregnancy was also a censoring event, which is sort of interesting in retrospect to think about because, of course, you can't force people to not get pregnant. So that sort of is a little bit of an odd definition of censoring, but that's in some ways how you can imagine this. So, as we said before, if we had run that ideal RCT, no confounding, no selection bias by design, very simple statistics. In HIV causal, there is confounding because there's no physical randomization of initiating a strategy. There's no forcing anybody to continue following any strategy. They're just doing what they're doing, and we're observing them. People, and in this case, for that reason, people who start earlier may be healthier or sicker, more at risk for death than those who start later. And again, there's also selection bias. Some subjects are censored. The people who don't get monitored for 12 months may be healthier or sicker than those who do. So the censoring creates a form of selection bias likely. So you can't assume no confounding or selection bias. That's completely unreasonable. But we might be able to reasonably assume or approximately assume no unmeasured confounding or selection bias. And if we can do this, we can, in principle, get at an unbiased estimate of our causal effect of interest. What does no unmeasured confounding mean? We can give a verbal definition. We'll also understand this assumption graphically using causal DAG. But verbally, we can state this as the assumption that the measured variables in the HIV causal data set are sufficient to control confounding and selection by unmeasured risk factors, in this case for mortality. This is an untestable assumption because it's an assumption about the relationship between measured and unmeasured variables. Since we haven't measured these unmeasured variables, we can't do a statistical test, for example, of whether this holds. It has to be just based on subject matter knowledge. So the reason there's sort of two important features of the assumption of no unmeasured confounding that motivate our use of the G formula for these types of questions and in this type of data. First, no unmeasured confounding allows for the situation where we have so-called measured time-varying confounders in addition to baseline measured confounders. So, for example, CD4 cell count in month K is measured. And we know it's predictive of future mortality risk, and it's also independently predictive of whether you will receive or not receive treatment at a subsequent time, because the doctor looks at your CD4 cell count to assess whether to treat you. So it's a confounder in this sense, and it varies over time, over the course of the follow-up after that baseline randomization time. And another feature of no unmeasured confounding is that it allows that these measured time-varying confounders are themselves potentially affected by your past treatment status, which is certainly true in this case because we know that treatment affects, being treated affects your CD4 cell count. It can keep it higher. So this gives a graphical representation of the structure where we could have no unmeasured confounding but measured time-varying confounding affected by past treatment. So how many of you are familiar with causal DAGs? Okay, so this isn't completely new. So this represents no unmeasured confounding generally by the fact that, so this is a simplified causal DAG where I just have a subset of time points and only CD4 is a time-varying confounder, but there are others here, viral load, diagnosis of AIDS. But here we can see that conditional on the measured time-varying confounders and potentially baseline confounders or confounders prior to time t minus 1, we can block all backdoor paths between the treatment at each time. Here's at time k, here's at k minus 1. So conditional on this, we block any non-causal way to get to the outcome, any non-directed paths, and same here. Another way that you can just read no unmeasured confounding off the graph is when there are no arrows from any unmeasured variable on the graph into treatment at any time. So this is that case. This happens to be that case. So I can just look at this and tell you this DAG represents no unmeasured confounding, but you can have other scenarios where those arrows, where maybe this arrow is there, and then I remove other arrows to get no unmeasured confounding. But generally, no unmeasured confounding is a restrictive assumption. I have to remove some arrows if there are unmeasured variables on the graph. But so it also represents the assumption that CD4 is a measured time-varying confounder in the sense that in this graph, it's predictive of the outcome. In this case, I've made it such that it's just associated with the outcome through this unmeasured risk factor. And it's also predictive of future treatment, and the structure holds at each time. And it also, we see that this arrow represents the assumption that this measured time-varying confounder can itself be affected by prior treatment. So this is just giving you a visual representation of those assumptions. So why do we care about this structure in particular? Well, it turns out that under this type of data structure, even though I'm telling you, given no unmeasured confounding, given we've measured a sufficient number of variables in this data set to control confounding, to control that bias and to control selection bias, we can't get at this unbiased estimate under the graph that I just showed you by a standard outcome regression approaches. We're going to need other approaches. So this is really what's going to ultimately motivate us. So why do we need other approaches? Well, what do we mean by a standard outcome regression? In this example, if someone said to you, I'd like to understand what's the effects of time-varying CART strategies on, say, the hazard of death at a given time, but I have this problem, and I know that CD4 cell count is a time-varying confounder. It's a common risk. It's a risk factor for the outcome and also for the exposure. We know this from standard epidemiology that that's what I think of when I think of a confounder. So what do I do? Well, usually when I adjust for confounding, I just put it in the regression model with treatment. So a natural thing to do would be to put, say, a function of the time-varying treatment. Maybe I put in a cumulative average of the time-varying indicators and have you initiated treatment yet. So I could do a lot of things, but that might be one model assumption. Then to adjust for CD4, I put, say, the cumulative average of your CD4 cell count through that time as well. And then use the estimated coefficient on the time-varying treatment function as a report of the adjusted causal effect of time-varying treatment in this case. Well, the problem with this is that even given we have non-measured confounding, in other words, given the graph that I showed you, which is consistent with that, and even given that regression model was perfectly specified, there's no model misspecification, that coefficient estimate is a confounded estimate under the causal DAG that I showed you. And the reasoning for that, some of you may be familiar with this argument if you've seen causal DAGs before, is that basically conditioning on that function of time-varying CD4 cell count is akin to conditioning on this node in the graph, which is a common effect under my assumptions here on this unmeasured risk factor in past treatments. And when you condition on a common effect of two variables, you actually create an artificial association between them, a non-causal association between them. So the coefficient on time-varying parts in my model is actually capturing this path as well as any directed paths on this graph. So it's capturing a non-causal pathway. So if not standard regression, then how can we proceed? And in this case, in other words, under the more general DAG that I showed you, that the only restriction is that I have no unmeasured confounding. I make no restriction on whether time-varying confounders are affected by past treatment. In this case, Robin's so-called methods that derive from Robin's so-called G formula can get us unbiased estimates in principle. In other words, they can give us unbiased estimates of time-varying causal treatment effects, the effects of time-varying treatment strategies, in our case, these initiation strategies indexed by X, in the face of the structure where we might have measured time-varying confounding affected by past treatment. So what is the G formula? Well, in a seminal paper in 1986, Jamie Robbins showed that given this assumption of no unmeasured confounding, which is again a non-parametric, it makes no model assumptions, it's just the assumptions are represented on that DAG that I showed you before. That's an assumption about that represents no unmeasured confounding. The counterfactual outcome mean, or risk in our case, 5-year risk, associated with a user-specified time-varying treatment strategy, which we can generally index with a G, can be written as the G formula, which is just a function of the data, a function of the baseline and time-varying confounders and treatments. And so in turn, estimated contrast in this function, the G formula, indexed by different choices of G, say our strategy X equals 500 versus our strategy X equals 200, can give us, in principle, unbiased estimates of causal effects. So in addition to this no unmeasured confounding assumption, this result also requires a so-called positivity assumption, which basically just guarantees that for a given choice of G, for our G indexing the G formula and our definition of the measured confounders, this function is well defined. It doesn't blow up to infinity. So what does this function look like? Well, we can write this function we can think of it as a weighted average in our example where we're interested in the effect on risk, 5-year mortality risk. We can think of it as a weighted average of conditional risk, where each risk in that weighted average is conditioned on a possible treatment and confounder history that we could observe under the strategy G and also under elimination of censoring or no censoring events. So we can imagine, for example, that under a strategy initiate cart, when CD4 first drops below 350 in the population, in the arm, let's say, had we implemented that intervention, we're going to observe different CD4 cell count histories, different viral load histories, different combinations of those, and of course there's going to be an infinite number because those are continuous variables, but we could imagine if we could just enumerate every possible one that we can observe, which maybe would be just each one for each person in that arm, in that treatment arm. We can imagine estimating the risk conditional on each of those possible histories we could observe. And so again, it's a weighted average where the weights are a function of the joint distribution of the measured confounders at each time, conditional on a history observable under G or consistent with G. Again, possibly X equals 350 and no censoring. So we can sort of more intuitively think of those weights, that joint distribution as just the chance of observing each confounder history that we've just enumerated. So you're weighting by the chance of observing that in the population. So in some cases, these weights will also be a function, in addition to the distribution of the joint distribution of the measured confounders, they'll also be a function of the observed distribution of treatment at each time, conditional on a path consistent with G. This will be the case when G is more generally defined in terms of an intervention that can depend on this observed distribution of treatment. So one example of this is the case where we make that M, that grace period, greater than 0. So in that case, so in the case where M equals 0, the intervention start part as soon as CD4 first drops below 350, that doesn't reference the observed distribution. We don't need to know anything about the observed distribution of heart initiation in that population. But if we said we allowed a grace period, we could think of that grace period as during the grace period, assign treatment according to the distribution of treatment in the HIV causal collaboration. Then at the end of the 6 months, start CART if you've met the condition. If your CD4 has dropped below 350, I'm going to assign treatment as a random drop in the distribution of treatment in this population for the next 6 months, and then at the end of the 6 months, I'm just going to force you to start treatment. That's a way to think about this grace period as well. So basically, I mentioned this because the G formula macro allows for these types of interventions that could depend on the grace period, or more generally could just be defined in terms of the observed distribution of treatment. So we allow the general case where the weights can depend on both the distribution of confounders as well as the distribution of treatment. So we solved one problem. We've now established that given no unmeasured confounding, we can, as we say, identify the causal effect that we want using a contrast in this fairly potentially complicated function in the data, this weighted average, indexed by different choices of G. So recall, if we had done the ideal RCT, the functions we would be contrasting were just these very easy sample proportions. Now, because we're dealing with time-varying confounding, to get at that same quantity, under no unmeasured confounding, we can get at it, but under a contrast of very complicated functions. And so this adds another layer of complexity, because really, when we have an infinite number of possible histories we can observe, which would be the case when these confounders are continuously measured, let's say, or otherwise can take on many levels, or you have many, many time points, then this weighted average is really a high-dimensional interval, and we certainly can't compute it via, say, contingency table analysis. So in this case, we need to do something to reduce the dimension of the problem. And we might require parametric models, or use adaptive approaches, or whatever we do, but we have to do something. So different methods rely on basically different ways of dealing with this problem. We can think of this as different types of parametric model assumptions. So the parametric G formula deals with this problem by imposing models directly on the components of that weighted average. In practice, algorithmically, the way we do this is instead of having a model for the risk at 5 years given the past, we have models for the hazard given the past, and they're computed into a risk, but it's the same idea. But other methods can be used which derive from alternative representations of this weighted average, which are algebraically equivalent in the absence of models to that weighted average I just described. But these alternative representations suggest constraining different quantities via models when, again, we're in this high-dimensional recursive dimensionality situation. So, for example, IPW of MSM what derives from understanding that this weighted average has an equivalent representation as a function of inverse probability weighted means. If I add another assumption called a marginal structural model, I can even put more parametric assumptions on things to further deal with recursive dimensionality. There are doubly robust methods like targeted maximum likelihood estimations. There are workshops going on both of these here. This has a doubly robust property, which is nice because you have sort of two sets of models you could get right. You can get one or the other right and remain consistent for the correct answer. And this method derives from yet a third representation, where you can write this weighted average as a series of nested conditional means. So there's a lot of ways to do this, and what I'm going to be focusing on for the rest of the time is one way that has some practical advantages and also some disadvantages as well. We'll talk about this. So now I'm going to go through the general algorithm. Basically, what we're doing underneath the G-formula fast macro. So it's cumbersome code, but it's not extremely complicated. It relies mainly on existing fast procedures. So in the first step, we fit parametric models for the discrete hazard at each time, given the observed paths, including restricting to those who are uncensored and still alive. This is what we mean by hazard. So by discrete hazard, we mean just the probability of dying in month k, given you survived to month k minus 1 and remained uncensored to k minus 1, and then also conditional on your whole observed treatment and confounder history through that time. So these are going to be used to piece together into that risk conditional on the path. But at this point, we're not even talking about a particular G, a particular strategy X. This is just a model that we impose on the data before we've even, talked about what the question is. And then we have a model for those weights, the joint distribution of the treatment and confounders. Again, the treatment is in there to allow for strategies like this grace period at each time given the path. And all of these models are generally going to be pooled over time. When there's a lot of time points, it's going to be practically difficult not to do that, but you can make these flexible functions of time, or you can, in principle, and you could set separate models for each time point if you had enough data. So I often get, there's often confusion about what do we mean, what are we actually doing when we model the joint distribution of covariance, because there's a lot of, that sounds very difficult and there's a lot of ways you can do it. So the way that we do it is we base this on an arbitrary factorization of the measured covariance, the treatment and confounders at each time k. So here, for example, if you just considered the two time varying covariance, CD4 and viral load in month k, this is the joint distribution given the path through k minus 1. I can equivalently write this just by the laws of probability as the distribution of CD4 given RNA times the distribution of RNA, or equivalently distribution of RNA given CD4 times distribution of CD4. That's exactly the same before I put down any models. So the way we model this is we pick a factorization and just model the components of that factorization. In the absence of any model misspecification, again, this is exactly the same thing, and it shouldn't make a difference. When there is model misspecification, your results could potentially be sensitive to this arbitrary choice of order. So, one type of sensitivity analysis to model misspecification could be to just make sure, okay, if I pick a different order, does this make a big difference to my results? And you'd be worried if it did. That model specification is a problem. And also, I'll just throw out there that in that 2011 paper, we talked about how deterministic relationships that we might understand from the data may actually favor one factorization over another. I'm not going to spend a ton of time on this right now. I can talk about it at the end if we have time, but you can take a look at the paper and there's some detail about that. So if, for example, I just knew something about this, then I might choose this instead of this because I could do a better job. Okay, so that's step one. I'm just fitting parametric models for these observed data quantities. And then in step two, I'm going to simulate a number of histories based on those model coefficients consistent with my strategy. So we'll say n times, where by default we can set n to the sample size. I'm going to run the following algorithm iteratively for each time k. So at each time k, n times, I'm going to simulate the treatment and confounders at time k using the estimated model parameters from that first step, from the joint estimation of the joint distribution of the treatment and confounders at k. The exception is going to be at baseline. I'm going to just assign the values in the observed data. I'm only going to simulate after time 0. So after I've simulated or looked at the observed values at the baseline time, I'm going to see, is this treatment value consistent with my rule G? So for example, if the rule is, let's start with something simple, never treat, if I simulated a 1 for treatment for that person, then I'm going to change it to 0. I'm going to intervene. This is not, we're not intervening on anyone, but we're going to reset to the value consistent with G. And then we're going to use the simulated history up to, so we're going to have done, so up to time k, we're going to have now, n times we're going to have a history through k that now has a treatment value consistent with my rule G. And then I'm going to estimate the hazard of the event using my parameters from my hazard model that I saved from step 1. And then, so in the more complex case, which is the example we've been talking about, start cart when CD4 first drops below, say 350, I'm going to look at this person's CD4 cell history, and then I'm going to say, if this person has no CD4 that has dropped below, or if the simulated history is such that there's no CD4 count yet that's below 350, and I generate a 1 for treat, I'm going to change that to 0, because this person should not be, given this history, this does not indicate starting treatment yet. Whereas if this person now at 10K has first dropped below 350, then I'm going to set treatment to be 0 if the simulated value wasn't, I'm going to set the treatment to be 1 if the simulated value was 0, was the wrong value. Okay? So you should have now n at each time k, if you looked at the CD4 history and look at treatment, they should be doing the right thing according to what your rule is. In this case, start cart when CD4 first drops below X. Okay, so now I'm going to have hazards conditional on each history through k for every possible value of k. So in our example, we were interested in 5-year follow-up, and our follow-up time is in months. So we have 60 hazards now that we've computed, because 5 years is 60 months. So what we're going to do is we're going to take those hazards for each of those n histories and compute them into a risk, which we can do via a 1 minus Kaplan-Meier computation. That's how that computation relates time-varying hazards to a risk in the presence of censoring. And actually in the absence of censoring as well. That is quite definitionally the same. And then, so now I'll have n risks conditional on each of those associated with each of those n histories. And my final estimate of risk under this intervention or treatment strategy G is just going to be the average of those history-specific risks. And then for getting my estimates of causal effects, I'm just going to repeat steps 2 and 3, the simulation step for G. So I'm going to change what G is and recompute the final risk, and then I can get a risk difference or a risk ratio for 2 choices of G, say X equals 500, X equals 200, and then there's no closed form for the variance here. It's too complicated, so you have to use the bootstrap to get confidence interval, so you bootstrap the whole process many times, say 500, 200, 500, 1,000 times, and including the first step 1 where you're estimating the model parameters. So this just gives a visual of that algorithm I just went through. So we can see in the first step, we fit the estimated model parameters. We're going to use those to generate n histories. And I'm saying this for simplicity, but you can also use, again, knowledge of the data where you have it in place of those model parameters. So for example, if I know that my treatment time-varying treatment variable, for example, is an indicator of treatment initiation. It's not just a binary variable that can flip 0 to 1 at any time. As soon as it switches to 1, it stays 1 because it's an indicator of initiating by time k. So for example, I don't want to just throw a model on the probability of initiating treatment. I really only want to fit that model given you have not yet started treatment. Because I know with certainty that if you started treatment, the rest of your values of treatment are 1. So I can limit my model for treatment in that case to only records where the previous value is 0 of treatment. And then when I simulate, once I simulate a 1, I'm going to just keep setting that to 1 because that's how it looks in the data by definition. So those sorts of things, and the same thing would be, for example, a time-varying covariate that's an indicator of first being diagnosed with a disease by time k, say diabetes. Once you're diagnosed with diabetes, you don't go up and down. So there are a lot of examples of those sorts of things that you should take into account as much as possible to be relying on, or minimize how much you're relying on arbitrary parametric models. So again, so we have either by models or by knowledge or when we do it by these n histories. We've got 60 hazards for each history. We put them together by a 1 minus Kaplan-Meier computation to get risk for each of the n histories, and then we just take an average to get the final risk estimate. So the key disadvantage of this method is that it relies heavily, potentially, on parametric model assumptions and is subject to related bias. And so when implementing this method, ideally you use flexible models. Ideally you have large data sets so that you can use flexible models. Ideally you incorporate as much knowledge of the data that you can. There's also, I sort of consider this part of the same issue, but in the literature, people consider it separately. But in fact, it's been shown that some model classification can actually be theoretically guaranteed under the DAG that I showed you before, where we have no unmeasured confounding, but time-varying confounding affected by prior exposure when the null is true. So we actually had a lot of conversation about this yesterday, so I think I should clarify it a little more up front. This has been called the null paradox in the literature. So the idea is that this is a theoretical issue. It doesn't mean that in a given analysis you can't reject the null. You certainly can reject the null. That you can't fail to reject the null. We've many analyses we've done in this place where we've certainly failed to reject the null. The problem is that it just means that the theoretical properties that we're relying on, if the null is true, and all of the other preliminary assumptions that we've made could be to some degree violated, so that this is in sort of a repeated sampling sense. There's some bias associated with your estimator. There's no guarantee how much. It could be very little. It could be a lot. It really depends on the data generating distribution. So we actually do plan to do some simulations to get a sense of what is the practical impact of this, but whether you think whether the null is true or whether the alternative is true, model specification is always a concern for this method, period. So, but in principle, if you fit very flexible models, then my inclination is to think that the bias associated with the null paradox is not guaranteed to be huge relative to biases you can find each model of classification with other methods, but we still really don't know. So the practical advantages of this approach are that it's when you have continuous exposures, this was the case in the example I gave yesterday, and that's the case here, exposures of many levels, or on a related note, given you have so-called near positivity violations, which can happen when you have, when you can observe a level of treatment that's consistent with G, that's very unlikely in the data for certain confounder histories. So, for example, if you have a certain CD4 cell count history, it's very rare to be treated in the data, but not impossible. In those sorts of settings, methods based on IP weighting can be very unstable. And in this, in the parametric T formula, you can get stable estimates in this case, but you're doing this, again, so sort of going back to the disadvantages, you're doing this by relying more heavily on extrapolation, basically in areas of the, you're relying more on models to get around this. Another practical advantage is that the complexity of the algorithm is essentially the same no matter how complicated the gene you're talking about is. So we're considering fairly complex dynamic strategies here. As you saw, there's only one spot in the algorithm where you actually specify what the rule is. How are you going to reset exposure given the path? Whereas you can actually see from this workshop, we have one workshop on IPW for static regimes and one workshop for IPW for dynamic regimes, because the algorithms actually are fairly different and the properties of the estimator are fairly different depending on what type of rule you're talking about. So the whole procedure becomes very strategy question specific, whereas from a practical point of view, this is sort of easy. If you're going to do it for a simple question, you can largely do it as easily for a hard question. Okay. So I have been very bad about keeping track of time. So let's see, we have till 4. I'm gonna. Are there any questions? Because that's sort of the end of the background part. Yeah. So we actually, I think the way we defined the treatment variable was an indicator of initiating by a particular time. So it's actually agnostic to what you do after that. I think the idea there was just we have no data to know whether people stay on treatment. All they have is whether a prescription was filled. So it's basically an initiation strategy, not a actually take pills every day strategy. Right, so basically the questions we're comparing are just when would you initiate based on CD4 count? It makes you could get off, after we have that data that says you filled first or prescribed this, we don't know what you did after that. Yeah, that wasn't accounted for, at least in this analysis. So yesterday was kind of a different situation, right? Because first of all, you're not the exposure there was daily fish consumption. So we're basing that on people's self-report of fish, which certainly can change as much as it changes. And you have more measurement error issue there, which is a whole other story. But yeah, so in that case, in the data itself, fish can be 3, then 5, then 2. Yeah. So the time varying aspect here is just we're starting over here where everybody starts at 0, and then people are going to switch from 0 to 1 at different times. But once they switch to 1, they say 1. No, so, no, please, I actually need, there's a whiteboard pen over here, so. This is great, because I think this is a smaller group than yesterday, so you can all so that we can all just move to this side. Oh, well, once they did it, they just left it open. Yeah. Yeah, so basically, you can... Oh. I have no idea how to do that. Okay, sorry, WebEx people. So yeah, you can imagine that there's sort of you're in the data, and actually we'll take a look at the simulated data set in a second. So maybe this is better to do there. But you're going to just have a bunch of different combinations of, CD4 cell count per person, 2, 3, and different, so different values of CD4 cell count at time 1, 2, 3, 4, 5, 6, and so on. And so they'll have a CD4, and they'll have some value of 0 for their treatments, they'll have a value of RNA, and then they'll have a different value of CD4 here, and maybe a 1 starts here, and so on. And you can imagine there's all these different combinations. So basically, I'm fitting a model for where the dependent variable, maybe I should say it this way, is just did you or did you not fail? And then I'm making the independent variables just a function of these time-varying variables, the time-varying treatment indicator, which is a 0-1 variable, continuous variable, CD4 cell count, RNA, so it's fitting just a regression model where the time-varying treatments and treatment indicators and the time-varying confounder values are independent variables in the model. And so there's going to be a bunch of data, estimated data coefficients on those independent variables in the model, and I'm going to just put them aside, and then I'm going to use them to simulate data. Does that make sense? Okay. This whiteboard wasn't really that interesting. Yeah.
Back to your comment about if your particular treatment strategy that you're planning isn't well represented in the actual data that you have, as opposed to trying to put out a research, I guess.
Yeah.
Is there any kind of, confidence interval or something that you get on how confident?
So the way so that's a good question. The way I tend to handle this in practice, I tend to not use this method alone. Usually I will couple it with an ICW estimator, and so sometimes that really isn't possible. For example, if I asked a question like, like our example yesterday, where we had a continuous treatment and always eat exactly 3 servings of fish versus always eat exactly 4 servings of fish, that type of question will it's not even possible to do that with ICW. The weight would just explode. But if we add something like this, and in fact there was a comparable ICW analysis that Lauren Kane talked about yesterday for this data set, this exact question. And we found that the confidence intervals were much wider for ICW, which is what we would expect, but the estimates were consistent with what we found. We found, that we couldn't. We failed to reject the null under a difference between these strategies, but the estimates were suggestive that it was better to start early, and here we were able to find, confidence intervals that didn't cross 1. So it's a tricky problem. And then doubly robust estimators, which I don't really have enough experience with to talk about here, but I actually would like to learn more about them in terms of how they work in practice. Those, in some respects, are supposed to give you kind of a middle ground, but they still rely on weight. So I expect that when you have a situation where the plain ICW estimator would really fall apart, I think that you still might have a problem in that case. But for some of this is really just, you can even just tell by looking at the data. Like if you try to find people eating consistently exactly 3 servings of fish for 18 years, you're going to look at the data and say, I don't have anyone in the data doing this. So And that's the kind of question that, you're really, you can answer it, but you're relying on models in the same way you would with regular outcome regression, but you're targeting a more precise question, and you're also handling this time varying confounding problem more appropriately. Okay. All right, I'm going to try to make a little more progress, and then maybe I'll take a 5-10 minute break. I think I could easily use up this entire 3 hours, so I think I will try to do that. But maybe when we do some of the hands-on stuff, if people want to take a break, we'll include it as part of that. So now we'll talk about how you might implement this with the G-formula SAS macro. So first of all, we're going to be focusing on this specific situation where we're interested in the effect on a risk or cumulative risk. But the macro handles 3 different types of outcomes, so I'll just mention the other 2. So, and the macro parameter that you specify to determine this is called OUTC type, so outcome type. How many people here have background at all with the macro programming language in SAS? Or okay, so even if you don't, I've helped people implement this who have no background in this. It's not, you don't really have to have that much background with it. But so this would be appropriate when you're interested in the effect of a time varying treatment strategy on an outcome mean at a particular point in time. So, for example, you wanted to know what is the effect of these part initiation strategies on your mean CD4 cell count at 5 years post-baseline. So that's a slightly different type of question than what we've been considering. Another type it considers is a binary outcome at the fixed end of follow-up. So this would be relevant if you were interested in, say, the effect of a time-varying treatment strategy or time-varying exposure intervention on the probability that an outcome occurs or the outcome equals 1, again, at some particular point in time, like the probability of being obese at 5 years post-follow-up. So we're focused today on the case where we have our outcome as a time-varying indicator of a failure event. In this case, all-cause mortality. So this you would choose when you're interested in a cumulative risk by the end of follow-up. So here, you define outcome type as bin served. That's the syntax you would use. So the macro expects a very particular data structure. It requires a person-time data set with 1 record per subject per measurement time, where the time index, which is included by the macro parameter time. So this is the name of a variable in your data set that indexes what time measurement we're talking about. And it must start at 0. It doesn't matter what it means. The baseline time, that variable time must start at 0 for every subject and increment by 1 at each subsequent time. And each time index is going to represent basically a time interval, I say in which covariates are measured, but really it should be a time interval in which covariates have the opportunity to change. That's really how you should think about it. So yesterday we talked about the Nurses' Health Study, where the data was collected every 2 years by a questionnaire. So naturally, the time interval was 2 years. There was no opportunity to make it any finer than 2 years. Whereas in this case, as I said, this is a clinical cohort. So some people are going to be coming in maybe every day during the 2-week period. Some people might not come in for 6 months and then come in for 3 days in a row. It's all over the place. So in this case, we really could have the time index be a daily time index. And basically, the covariate at times where someone isn't there can be just viewed as last measured values of these covariates, which is basically relying on an assumption that the last measured values are sufficient to control confounding. So in this kind of scenario, that actually might be reasonable because you're basically what you're assuming is the last measured value of CD4 that you have is the last measurement that the doctor saw to determine when to initiate treatment. So, that's effectively what assumption you're making. And I'll talk about this at the very end if we have time. And we'll see this in the simulated data set, that you can also have indicators for measurement process, we call it. So, for example, if you had your CD4 measured at time 2, then I can have another variable that indicates that was an actual measurement at time 2. And then if you didn't have another one until time 5, I would keep carrying forward until a new measurement at time 5, but I'd also have that indicator would switch to 0 at the time that wasn't a real measurement, and you can make that time-varying visit process also part of the confounder history, because it reasonably could be viewed as part of this. You might need that to control confounding. People who come in more frequently for lab measurements may be different than subjects and more likely to be at risk for higher risk for mortality and more likely to be treated, probably more likely to be treated because they're in the clinic more. Okay, so in our case, we made the time index, again, a month-long interval simply for computational reasons, because we had 5 years of follow-up, so to turn that into 365 times 5 became very big, but in fact, the computation since 2011 has changed so much and improved so much that, in fact, I think we might have no problem doing that now. So generally, each person time record will include time 6 baseline covariates. These are baseline confounders, sort of fixed characteristics of the subject or something about the history of that subject prior to baseline. So, for example, their race, sex, pre-baseline measurements of the time-varying confounders like CD4, viral load. It will also contain current covariate measurements for each time. So these are the time-varying covariates. So on each timeline for each subject, these have the potential to take a different value, like CD4, RNA, whether or not you've initiated CART yet. And then we're also going to have, in our case, a time-varying indicator of whether you've been censored yet by a particular time. In this case, for example, an indicator that you've now reached 12 consecutive months without a measurement of CD4 or RNA. That was part of our definition of a censoring event. So in the case where we have outcome type FinServe, where outcome is a time-varying indicator of failure, we're also going to have a time-varying indicator of that failure event, in this case all-cause mortality, for each time index in the data set. And this time-varying indicator of failure is allowed to have one of 3 values. It will be 0 on a given line K if neither the event nor censoring has occurred by that time. It will be 1 if the event has occurred, and it should be missing if the subject is censored at that time and no event has yet occurred. And the first line where a subject is censored or has the event is the last line you keep in the data set, because we don't need it. We have no more information we can use on the subject at that point. So this just talks about that, there are going to be some subjects who never fail up to the 5 years and who are there through the whole 5 years, and so they're going to be zeros on that time-varying indicator of failure and censoring all the way up through the 60-month line. The macro parameter time point is going to define the end of follow-up of interest in terms of interval. So again, we're saying we're interested in risk by 5-year follow-up, which in terms of intervals is 60 months. So time points here would be set to 60. And because, again, the time index must start at 0, the maximum value of time in the data set for people who make it all the way to the end is going to be 59, because we start at 0. Okay, so now we're going to just look at, I have a simulated data set, which if you have access to SAS Studio in there, you can open it up. So I have a file called HIV descriptive. So I'm just going to run this, and it has some proc print statements in it that will let us take a look at a few observations. So, and what some of this looks like. So, forgot I had this guy with me. So this is just one person's information from the simulated data set. This is ID number 95,000. I probably should first scroll down at so many times that I don't, oh no, you can see the whole thing on the screen. So this person here is the, so month is my variable that I assigned to the parameter time. That's the name of the variable in my data set that indexes the follow-up time. It has to start at 0. This person doesn't make it to time 59. This person's last record is at month equals 35, so he has 36 records in the data set. And he's not there because he was censored at that time. And you can see you have to code his outcomes with him. In fact, yeah, so I don't know why this person, anyway. This is that treatment indicator. So this person was censored and never started treatment. That's why it's all zeros. This is the log C4 count. We put it out on the log scale. So you can see that, and we also have a visit C4 variable, which is an indicator of whether this is a current measurement or a last measurement. So the first measurement, we had pre-baseline measurements, so that was probably carried forward from whatever the pre-baseline value was. It keeps getting, you're going to see it's the same until this switches to a 1, then it's a new value. It's going to see the same until it switches to a 1, then it's a new value. Same for log viral load, we have an indicator for that. This is a time fixed variable, so this is going to take the same value by definition for all records. And yeah, so this is an illustration of some of the variables in the data set for a person who is censored. Then we also have, this one is a little longer. So this one is an example of someone who died. So you can see this person, this is ID 95,026, and this person, you can't see the person going off the screen, but this is the death indicator. So this person's last record is month equals 42 because they died in that month. And this person also never started treatment. And similar. Okay. Okay, so now we're going to go through just some features of a basic call to the macro, what that would look like. So this is basically very close to the file HIV call1.fast. You can look along with that, or you can look along here. I just kind of blown up the syntax and put some the typeset and put some descriptions. So usually the first thing you're going to have in your file is setting a permanent library, probably at minimum to call in your data set. You'll need to do that. You'll need to have an include statement that calls the file that contains the G-formula macro. So the G-formula macro, you're welcome to take a look at it. It's in this file, gformula.fast. It's probably thousands of lines of code, so you definitely don't want to include it in your call. So you can just use this include statement so you don't have to look at it, and you can just focus on the call. I often have some options in here for myself for debugging if I need that, and this is just I decided to pull this permanent data set into the work directory. So those are sort of just some basic setup issues. Then before you call the G-formula macro, you're going to actually be defining your interventions using by defining global macro parameters. So this is just the way we set this up. It's not really ideal, but the syntax is very easy, I think, to follow once you have examples. So here I'm considering 2 interventions, and we're going to start with static interventions to keep it simple, and then we'll consider the more complicated case of coding the dynamic X cutoff regimes. So here we have let enter 1 is the first intervention I want to run. Remember, I can repeat that simulation for as many interventions as I want to construct risk ratios or risk differences. And here I have a second one, let enter 2. I'm doing this for never treat, and I call this always treat, but in fact, as we're saying, this is an indicator of initiating treatment, so really what this means is initiate it at time 1 in this case, because then you would be 1s for everything. So I'm actually going to go through the details of that syntax after I go through the call to the macro, so we'll keep in mind we're going to be defining the interventions above this, but we'll go through the syntax for that afterwards. So this is what the basic syntax for calling the macro looks like. Whenever you call a fast macro, we have, again, in that separate file, we've defined a macro that's called gformula, and the way you call it is a % sign and the name of the macro, open parentheses, close parentheses, semicolon, and then you're setting values of macro parameters that we've defined with the macro. If you look at the macro, there are hundreds of macro parameters. There's a lot of things you could potentially define, but a lot of them have default values that often you're not going to touch. But to use this in a more flexible or difficult way, sometimes you may add many more parameters to this call. This is going through kind of a basic call. And in the documentation, we have some we're trying to add a sort of more enhanced FAQ section to sort of talk about how you might do more complicated things. So at minimum, you're always going to define the name of the data set. So the macro parameter data will have the name of your data set. Again, it has to have the structure that we talked about. This macro parameter ID is your subject identifier in the data set. So we saw each ID is going to have a lot of lines, depending on how long they stay in the study before having the event or being censored. In this case, my subject identifier variable was also named ID, but you can name it whatever you want. Time is going to contain the variable with your time index counter. So this was called months, we saw. Time p-type is going to specify the function of time you're going to use for fitting the pooled over time model. So those models that we're fitting are going to generally be a function of time. For example, here I have 60 time points. I'm not going to fit 60 different models for these distributions at each time. In principle, I could. I'm not sure actually that the macro allows you to do that. It's sort of assuming you're going to use pulled over time models, but you can use, there are several options for using more or less flexible functions of time. So this is, there are 6 choices you can use for this macro parameter, and they're listed, I believe, under table 2 in the documentation. We're going to talk a little bit about the syntax for some of these options. But this is the case where we've assumed it's a linear function of time, but we could allow restricted cubic splines, or we can allow categories and indicators of time. There's several options for that. Time points, again, is specifying my end of follow-up in terms of intervals. So here, 5 years is what we're interested in, so this is 60 months. This is the outcome type. Here we're working with binserv again. OUTC is the name of the variable that has my time varying indicator of the event. So in this case, it's death. Sense lost is my my time varying censoring indicator. Again, that's going to be 0 until it could stay 0 if you're never censored, or it switches to 1 if you get censored. So this I call censor. Num_int is the number of interventions that I defined using those global macro variables above the call. So in this case, we're considering 2. The macro will also always estimate the risk under the so-called natural course. I don't remember if I added a slide on this, which is basically we can think of it as an intervention where we can think of it 2 ways. One as always assign according to the observed distribution in the data. And when it works out algorithmically, as is when you get to that step in the simulation step where you simulate the treatment, you never reset. You just leave the simulated value. So that's, and we'll talk a little bit about why we do that in a moment. But it will always output that, and actually by default it will always use that as the reference intervention when constructing relative risk or risk ratios, and you can change the reference using the parameter ref int. That's in the documentation as well. And we'll see that in some of the calls here. CIMPOD is a list of the time-fixed baseline confounders. So these are just listed as is from your data set. So for example, here I have just straight up the pre-baseline value of RNA, pre-baseline CD4, pre-baseline age. By including them as is, these are going to get included in every single model by default. So I'm making pretty strong linearity assumptions here by just putting them straight in as is. If I wanted to be more flexible, I could put in square terms. I could, in another program I was saying yesterday, there's what we do to create restricted cubic splines within the macro is we use, I think it's an existing SAS macro called RC spline. You can use that on a baseline variable and it will output, you use 4 knots that outputs, I think, 3 variables that you just list right there. Or you can just use indicators of categories, but the idea is just like with any regression modeling, when you just list these as is, you're making a linear assumption, which is typically a strong thing to do. And this is here since HIV, since you got HIV. So this CIMPOD is a list, and it should be separated by spaces, not commas. Each of the parameters themselves are separated by commas. So here, so encode is the number of time-varying covariates, including treatments, and you can include up to 30 of these. There's sort of a cap on how many you can include. We have had one application where we use 30 covariates, and we need a lot of data to do that. So here I just illustrated this. I think in the actual call I have 4 time-varying covariates, but I couldn't fit them all on the slide, so here I'm just showing 2 of them. So this is the log CD4 cell count. I'm listing this as covariate 1, code 1. Code 2 I've listed as the treatment art. So before I say anything else, remember I said that the way we model the joint distribution of the covariates at each time k is by just picking an arbitrary factorization, and the order is arbitrary in the absence of volume specification, but you could do sensitivity analysis to be sure. So the order that you list these is choosing that factorization. So if you wanted to do sensitivity to that, you could just flip the order of what number you list, what you attach to code 1 or code 2 or code 3 and so on. So code 1 of the O type and P type attached to each covariate is what's going to determine how we model these covariates. So the code O type, code 1 O type, for example, is going to tell me what SAS regression procedure and other specifications I'm going to make when I try to estimate the piece of that factorization that corresponds to the conditional distribution of LNCD4. And P-type is going to tell me what function of LNCD4 history I'm going to use in other models. Because remember, every model is a function of the history of all covariates up to that time. So each covariate gets modeled and also as an outcome, that's why it's called O-type sort of intuitively, as a dependent variable in a model, and also will show up, some function of its past will show up in as independent variables in all the other models. And then n samples here is the number of bootstrap samples. So another important macro parameter to be aware of is this run graph, which if you set it to 1, it will the program will automatically output graphical comparisons of the what we'll call observed risks, and I'll explain that in a moment, versus the natural course risks at each time. So the natural course risks are going to be my risk estimate when I run the macro, where every time I simulate treatment, I don't reset it at all. So it's effectively under no intervention on treatment, but a model-based estimate of the population risk under no intervention, and we call that the natural course risk. We actually can continue to think of this as an intervention on censoring, because we're still restricting, of course, to no. Every model is restricted to those who have remained uncensored, and so from a causality counterfactual perspective, we have to think of this as under elimination of censoring events. So it's not exactly an observed risk, and sort of in a misleading way, we call observed risks non-parametric estimates from the data of risk. In other words, a 1 minus Kaplan-Meier computation applied simply just to the observed data, no models at all. So, in fact, I mean, this isn't often, we don't hear this in the statistical literature, but if we impose sort of a counterfactual causal bag thought process to this 1 minus Kaplan-Meier computation, this is an estimate of the risk at 5 years under no intervention under independent censoring. In other words, no selection bias due to censoring. Whereas the natural course risk is an estimate of that same quantity, but under a more relaxed assumption on censoring, more relaxed causal assumption on censoring, in that we allow no unmeasured selection bias. In other words, time varying covariates that are risk factors can be selection factors or causes of censoring, and that is still a valid estimate of the risk, the natural course risk, except it's very reliant on model assumptions, so we can be getting bias there. So, and there's an analogous output comparing observed means of covariates in the data, like LNP per cell count at each time, versus the simulated covariate means in the data under no intervention. So the reason that we output these is that this isn't a goodness of fit test, but looking at sort of patterns of divergence in these graphs can be an alert to gross model misspecification. And the practical way that I found these to be useful, of course, we never know if we have model misspecification in these high-dimensional settings, and we're not using, because there's so much going on here, we can't even use sort of results for best fit data adaptive procedures on the individual models, because that doesn't guarantee us anything on the final estimator as a whole. But I have found that sometimes when you see a major divergence in these graphs, it can be, and it identifies that there's something deterministic about the data that I forgot to incorporate. For example, when we first did this analysis, we forgot that we were censoring individuals when they had a 12th consecutive missing RNA or CD4 cell count visit, and we were including in our time varying confounders those visit indicators. So we had to be modeling those as well, and we weren't accounting for the fact that there was a mess, there was a cap on how the sum of those visit indicators. And so we actually now have options in here to allow you to incorporate that information and basically restrict, when you simulate such that you're also capping. You can't just keep going with visit indicators continuing to be zero forever, because that's very discrepant from what's happening in the data. So there are things like that at least in terms of model misspecification can be identified. Whether it makes a huge difference to your causal effects is, sometimes it may make very little difference. Okay, so let's take a look at the output. In a minute, does anybody really need a break? Sorry to me. Putting them on the spot. We're almost at the sort of looking at code part, so at that point I would say you won't miss me talking. We'll go back to the so I'm going to pull up this HIV call 1. So here this is a little different than the than the one I showed before because I have 4 covariates. So NCOV equals 4. I have LNC4, log RNA, an indicator of an AIDS diagnosis by time month K, and then this indicator of initiation of treatment. So if we run this, we can take a look at the, so this runs a little longer than the program we had yesterday because this is a much bigger data set. I actually cut the time point. It was originally 10 years, this simulated data set, but it was really taking a long time to run. So, this should be and I have options note set, so if you didn't set that, all those notes would be showing up. So this basically just gives some usual output. You can actually set the parameter, I think it's called minimalistic, and if you set that to yes, then it will suppress a lot of this initial output, but the default is no, so it will usually print it. So this just shows you the output from the fast regression procedures that are run based on your choices of the P types and the O types, and we'll talk about some of the options for that. So you can actually take a look at what variables are being included in your model based on, even if you're not clear entirely from the documentation what it means, what you've selected. And hopefully it's clear, but if it's not, you can just look at this output and see what it's doing. So this is giving you models for the outcome. The first one is going to be the response variable is death, and then it has one for code 1, 2, 3, and 4, all the way down to the treatment model. So the next set of output it has is this mean, min, and max under each intervention. So the intervention 0, there's labels below this. Intervention 0 is always the natural course intervention. So this is showing you, also this is a little misleading. These S, death 1, and so on, these really, in my opinion, shouldn't be in the output. They're just estimates of the conditional hazards in the simulated data set, the average of those, so they're not actually, they're really kind of meaningless, so I wouldn't pay attention to those. But the next set after that gives you these S ln CD41, that will go all the way down to S ln CD460, S ln RNA1, S ln RNA60. That gives you the mean, min, and max values of the simulated values of CD4, ln CD4 at each time, and ln RNA at each time, and so on in the simulated data set. So this is under a simulation under no intervention, where you simulate and you don't touch the treatment. The next one that shows up will be your first intervention. So then you get the mean, min, and max under intervention 1. That was, I believe, always treat, or really what we mean is initiate treatment at time 1. So one always good thing to check is if you look at the simulated values of ART, the treatment, they should be 1 across the board at every time. And yesterday we were looking at an intervention that maintained fish consumption at a minimum of 3 servings per day. You should see that the min is 3 across the board. So that could be an alert to, did I do something wrong, if you see something unexpected there. And then 2 was never treat. So again, we looked down at the simulated treatment variables, and there's 0 across the board, which is what we would expect. Then we get to sort of the main results, which is, so you have this these labels of what you've set, the natural course is set for you, but the other labels you've specified. This gives you that observed risk, which is just that non-parametric estimate of risk under no intervention. It gives you the sample size, the number of subjects who are in the data at baseline. And then Monte Carlo sample size by default is going to be the observed sample size. This is that, remember we had, there were, in the algorithm we simulate N histories, that's your Monte Carlo sample size. So right now the program allows you to pick a smaller number than the sample size because, for example, if you had a sample size of 1 million, you can approximate that weighted average or that interval quite well, probably using 100,000 random sample of those 1 million observations, and you cut your computation time down, but usually we leave it at the sample size. This is the estimate of the risk under the natural course. So we want to actually look at this compared to this number, sort of that gives us a sense of the very first time I ran this, I think I got something like 2 over here and 10% over here, and that's a big red flag that I was really doing something strange with my model. So that's kind of a good test that, you know, I had all linear functions and very inflexible, and so that's a good thing to look at. And here we see this is we get, not surprisingly, this is a simulated data set, of course, but in fact we see this in real data too, that it is a good idea to always treat versus never treat. Never treat that increases your risk, and natural course is somewhere in the middle, because in that data set people are being both treated and not treated as they would in the real population. And then in the one below, this gives risk ratios. This gives you estimates of the risk ratio. I actually think I set the reference intervention using, if you look up at the call, I set reference equal to 2. So I used never treat as the reference intervention. But if I didn't set that parameter, it would have used the natural course as the reference intervention. And if I had set n samples to be greater than 0, it would have given me confidence intervals for these quantities. And I'll also just point out this, because I'll bring it up later, the macro incorporates, when you use sort of preset interventions like canned interventions that we define for you, like always treat, never treat are examples where you just have an in type that you can select. It will be keeping track of how many times did you generate a value that was inconsistent with your treatment rule. So in this case, percent intervened on is basically saying the percentage of times that I changed the value of treatment because it was inconsistent. So as I'm going to show you, which is very important for this example, we have an option which really I kind of universally use because most of my questions don't fit into the pre-canned options. We let you code your own intervention and basically supply some user-defined code. So this is what you would have to do for these cart interventions, and I'm going to show you the code that you can use for that, and you can always modify it for new questions. But in order to keep this making sense, you would actually have to code that tracker yourself in the user-defined code. This has nothing to do with your risk estimates. If this is incorrect, you can just ignore it. But just keep that in mind. There are some aspects of the output that when you're coding user-defined interventions, you would have to. So we have examples in the documentation that would show you how to add that stuff in when you're coding your own interventions. But this is unaffected by that in your confidence intervals. Okay. And then, I wanted to show you quickly the graph. So this is should just be the same call, but I have run graph equals 1. So this is going to give me an error because when you do this, it automatically creates a PDF file with the graphs that will save to your current folder, and I'm not allowed to save things here, but it actually also shows you the graphs at the bottom of the output. So if you ran this on a computer where you had permissions to save things, it will also output a PDF file that you can that will have the graph saved. And you can rename that graph using the parameter graph file, I think is the name. Otherwise, it gives it the name gfile.pdf, and that will just show up in your directory. So I should have. Here we go. So now, because I did run graph equals 1, after these simulated values, it sort of has some big ugly versions at the top, and then it has some nicer versions of the same thing underneath. So yeah, so this is what the PDF will look like. So you can see the red line is the observed risk at each time, which is, you can see, is not smooth because it's a non-parametric estimate. And then the blue line is the natural course risk, which is smooth because it's a fully model. It's based on the parametric models. And this is sort of misleading. This is giving you the differences at each time, but the scale is kind of short. So these actually look bigger than they are. Then next you get the means of the covariance at each time. So you get the observed and the simulated mean. So these actually look like just from an eye point of view. So for A's and art, they actually look pretty good. I don't think I could ask for better than that, but CD4 and RNA are looking a little off. So you'd want to think about, is there something I'm missing here about something I know about CD4 cell count? Do I need to use more flexible models here? So this might be something you could try to do a little better with. And again, when I first did this, I think it was our art variable was sort of like this, and then it was like going like completely, really not acceptable. But again, this is not a goodness of fit test. This is sort of just an ad hoc way to identify growth model of specification. Okay. So typically when we apply this, we aggressively apply sensitivity analysis and report, we tried this, we tried this, we tried this, and if something drastically changes, we report it. Okay. So now we're going to talk a little bit about the options for these O-types, the choices you have for how you model each time varying covariate given the path. And also this will determine some features of how this variable is simulated. So the options for COV-X O-type are summarized in Table 1 of the documentation, and there should be quite a bit of detail there, but let us go through a couple of examples. So O-type equals 1 is for the straightforward case where you just have, you assume a logistic regression model for the variable. So this would be maybe appropriate for a binary variable that can take the value 0 or 1 at any time without restriction. You're still making a logistic assumption. For example, it could really follow a probit distribution. I mean, it's still an assumption, but this would make no restriction on the variable being allowed to take 0 or 1 at any time. And the simulation is just based on the estimated model parameters from the logistic model. By contrast, COV-X O-type equals 2 would also be appropriate for a binary variable, but again, for the case where we have this type of variable that once it switches to 1, it stays 1. So in this case, the model is internally, if you pick O-type equals 2, is only fit to records where the last value of that variable was 0, and then when it simulates, it only simulates from the model if the last simulated value is 0, otherwise it just keeps carrying forward the value 1 if you last simulated a 1. So again, this is intended to try to keep that feature of the observed data in the simulated data. And then, for example, if you had a continuous variable, you might choose COV-X O-type equals 3. This just gets a standard proc reg, and it simulates under a normal distributional assumption. We have some other distributional assumptions for continuous covariance, like truncated normal. There are other options you can choose. So in contrast to the O-type, the P-type will determine how the history of that variable will appear in other models. Again, we're fitting a hazard model that's pulled over time, so how it will appear in that hazard model, and also models for the conditional covariant distribution. So these are listed in Table 2 of the documentation. I'm going to go through this, and then we can I'll set up what's the example will be, and then you can have a break while you work on that example. There are several options for COVAX p-types. So several of them begin with the prefix lag1 and have a particular suffix. And we'll talk about the suffix in a minute. But if you choose one with a prefix of lag1, this will include a function of one lagged value of that covariate as the function of history in other covariate models. And it will, in the hazard model, it will include only the current value of COVAX. So again, you can actually look at the output of these models if this is confusing, to see when you pick these, what is it including? Is it including only one value? Is it including the first and the lagged value? What is it doing? If it's not doing what you want, you can pick something else. And so the function of this lagged value that it includes in the model will depend on the choice of suffix. And so before I go into what those choices are, if you pick a p-type that has prefix lag1, you actually have to include in the input data set a variable that's called COVAX underscore L1. So if COVAX is LNCD4, then you have to have a variable in the data set called LNCD4 underscore L1 that is the lagged value of LNCD4. So basically, it's going to sort of, you'll see that it's equivalent, when you look diagonally. So you just need, if you're going to use this type of p-type, you just have to make sure that's in your input data set. So the function, again, is going to be determined by the suffix. So for example, lag1 bin basically will make no transformation to that lag1 variable. So the bin really is sort of historically comes from the fact that might be a reasonable thing to do if this was a binary variable. But if it's a continuous variable, effectively you're making a pretty strong modeling assumption. So if you wanted, there are other options. If you wanted to use more flexible models, you could use lag1 QDC for a quadratic function. You could include lag1 cat to, it'll automatically create indicators of categories of that variable. If you do that, you also have to specify COVX knots, which would specify the cutoff for those categories. So actually, I talked about this yesterday down here in the notes. That the internal way that these categories are created. So first of all, the COVX knots would be specified again as a list separated by spaces. So in this case, it would be creating indicators less than 4, greater than or equal to 4, less than 6, greater than or equal to 6, less than 8, or greater than or equal to 8. And it will always put the highest level as the reference category, I believe. So that's sort of, it does that internally for you. And then similarly, if you choose lag1 FPL, it'll create restricted cubic spline functions, and you need to specify the knots using the same syntax as for cat. And the same idea is hold for p-types that start with lag2 or lag3. There are options for lag2 and lag3. So again, this will include a function of the two most recent lags. So this is a more, you're including a richer function than history in that case. And the function, again, will depend on the suffix, and the definitions for the suffixes are the same for lag1, lag2, lag3. So cat would create categories of the last two lags, and so on. You'd have to specify the knots. And again, here, analogously, you'd have to include then variables, let's say LNCD4 underscore L1 and LNCD4 underscore L2, the two most recent lags, if you want to use this option, and analogously for lag 3. There are a number of other options you can pick, and I'm not going to go through all of them. This is just a subset of table 2. So for example, you could use, you could assume, include a function as the cumulative average of that variable from baseline all the way up to time k. That's another function of history that you could pick. and there are a number of others, and so these are, you can go through table 2 and take a look at those. So, okay, this is the first hands-on exercise if you're interested in playing around with the code. So if you want, you can take HIV call 1.fast and change the p-type for LMPD4 so that instead of including it as a linear function, it's a linear function, the history of LMPD4, you include indicators for categories of its first lagged value. And I just give you some cutoffs you can use that were approximately the 25th, 50th, and 75th percentiles in the data. And then you could also try adding another baseline confounder to the macro call, the variable sex. Or you could go stretch your legs. And if you get stuck, I'm happy to come over and help you out. What's that? Oh, okay. Thanks for joining. Hi. Hi. Oh, thank you. We should get away from the WebEx.
It's certainly, I would say the concept of fairness and also is probably really dangerous in terms of efficiency. A lot of users get when you're using efficiency, for example, you can use some low-rated orthography that is starting in your water assumption, but you really don't want to do that. It's also increasing but perhaps would that give you the same estimate outside the family cost, or is this actually happening in something different? Well, so the way I would think about here, so multiple institutions from income area, when here you could apply actually multiple institutions of income as well. This doesn't really what I'm usually doing, I'm actually including outcome. So if the only outcome, the only difference value is the outcome, I think that this is the same, because you're just conducting something using the model, and you're not physically reviewing them. And the fact that you're stopping is something that we're only using one efficiency, I'm not computing for subject. I'm not thinking about this computing for subject. I'm thinking about this more as actually a function, the formula that is identifying what I want. But I think that if the only model you're using for education is the outcome model, and you're using two average models that I'm using, I think it's the same. The variance might be different because we're using these stuff and we're using resolution, but maybe it's kind of that's how it's more information. In terms of the time varying variable, so yes, if you're using variables in that case, but again, remember, it also depends on how you analyze the data. I mean, that's what computing outcomes and well, yes, so basically I can include under the MRI function if the subject continues to repeat it, for example, that's kind of so that's a little more complicated. Yeah. So it's not really intention to repeat, it's more repetitive. So if you I think I would have to know what the details of I think you look through the process. Yeah, but I would like to talk more about this. Yeah, there's time message that we can talk more. No, I'm not thinking English. Yeah. Yeah.
When you start making your own substitutions, how do you get what is the best way of looking for the distinct which
Right, so that's a good question. So I don't know if I should be doing this with the microphone because when that people don't know, but I mean, so the question is that how do you know to what extent you're extrapolating with this data, and I mean with this approach, and I mean I think again I think of that as a source of model misspecification. I mean basically how far are you from the data, right? If you think about sort of an imaginary true population and this is a random sample, maybe you're never going to perfectly fit models to the data in these high dimensional settings, but I think it's useful, again, if you can, to try another method like IPW or one of these other methods that goes after the same function, this G-formula function, but under completely non-overlapping model assumptions, so you get similar results that would certainly suggest that your model specification is not driving your results. I've also there's an interesting
discussion of this in a paper, I think it's a 2012 paper by Peterson et al., where basically they recommend always using an IPW estimator, even if it's a case where the IPW estimator you would think would sort of be extremely inefficient, because extremely wide confidence intervals for an IPW estimator, which is relying much more on the data, could be a signal that your other approaches like this one are really just heavily relying on models. So the IPW like extremely lack of information as evidenced by the confidence intervals of an IPW estimator is sort of a good suggestion that not that your answer is wrong, but just that it's not not heavily supported by your data. It's being heavily supported by your data as they estimate the model the coefficients of these models. So how is everyone doing with the exercise? Everything figured out? It's fairly straightforward. Should we like look at the solution or move on? How does everybody? I think we're actually doing okay on time, but how many people want to look at the solution? Okay, I'll just pull it up. So I put the solution in HIV exercise 1.fast. So basically, to add the baseline confounder, I'm just going to add sex to the fixed code call, and to change the p-type for CD4, I'm going to change it. Oh, I think I actually changed this to blinds, but I actually did something different apparently. But before this was lag1 bin, which was a linear assumption. That's a pretty strong model assumption. So I changed this to lag1 SPL, but I could have done lag1 cat. And then I have to specify cov1 not separated by spaces. Okay? Okay, so let's move on to the interventions, because this is probably the most challenging part for this type of question, because for this example, you have to code your own user-defined interventions. So we're going to look at the case where you use a sort of pre-coded intervention that we sort of have automatically in there, and then the case where you would code these more complicated dynamic regimes. So in general, as I said, interventions are defined before the call to the main G formula macro, and these global macro variables, interv1, interv2, which one specifies your first intervention, two your second, and you can specify as many as you want. There's no limit, and that's with the let statement. And we'll look at the syntax again in a minute. Table 3 in the documentation describes the different available sort of pre-canned interventions, and really the only ones that I've used or found useful are the type 1, which is a static intervention where you can specify the value that you set treatment to, say always 0, always 1, for the fish consumption example, always 3 servings, let's say, or the so-called threshold interventions, which we've written several papers about, which basically is a way to maintain a continuous treatment within a pre-specified range. So we've written about that a lot in the context of the nurses' health study, for example, interventions that maintain behaviors like exercise at or above 30 minutes per day, or fish consumption at or above 3 servings per day. So there's a number of papers on that in the references of the documentation if you're interested. But otherwise, I find that really you sort of need to code your own, because that's really the power of this approach, is that you can be very flexible in the type of interventions. And again, you never need to define the natural course. That's always run automatically. You can change the reference intervention by the ref_int parameter in the gformula macro call. And also remember to keep track that you're defining the number of interventions also in the gformula macro call with that num_int parameter. So it's sort of easy to forget that even though you're defining these above, you still have some things in there that depend on what you defined above. And I'll just mention, it's not really relevant here, it was relevant yesterday. In a given intervention definition, you can actually consider joint interventions on multiple variables, and you can include up to 8 treatment variables. So for example, yesterday we considered a joint intervention on meat and fish. So that would all be part of, say, let interv 1, because even though it's 2 treatment variables, it's part of intervention 1. That isn't really relevant here. We're only interested in the cart initiation indicator. So the syntax is as follows. So we're going to do this %let interv 1 for the first intervention. It would be interv 2 for the second, and so on. Then we have the sort of redundant required syntax equals int no equals, where this number is always going to match that number. So that's sort of an unfortunate way we have it coded right now. But then you can put a label. So say never treat. It will go in these sort of single parentheses. N_var is the number of variables to undergo intervention in this intervention. So as I said, you can have up to 8. In our example, we only have 1. But in our meat-fish joint intervention, that would have been 2. And then for that first intervention variable, or for each intervention variable, we're going to have a number of specified parameters. So because this is the first one, we have a 1 after each of these. But if we had like a joint intervention, we'd have to define int_var 2, in type 2, and so on. That would correspond to that intervention variable. So here, our only intervention and first intervention variable is this art initiation indicator. I put in type 1 equals 1. If you look in table 3, this is how you define a static intervention. When you choose in type 1 equals 1, you have to define an int value 1, which is the value the fixed value that you'll be setting at each time. So for never treat, this would be 0. This is actually unnecessary because it's the default value. You don't have to actually include this explicitly. This just says, with what probability am I going to implement this intervention at each time? So you could actually, if you set that to 0.8, you could implement that intervention only 80% of the time at each time k. I've never used that in practice, but the option is there. And then this is another unfortunate current part of the syntax, that instead of the default being intervening at every time, the default is intervening at no time. So you have to have this very long list of every single time. And so because we're intervening at every single one of these 60 months, I have to start at 0 and go all the way to 59. So that's kind of a very not clean syntax, but you just copy and paste, and you have to do it a few times. So now we can talk about how to encode user-defined rules. And this is really, for any one rule, you could actually probably code many different ways, depending on your style of SAS programming. These are hard for us to pre-code as options because we don't know what your data set looks like, we don't know what your rule is going to be, and really you could have that rule be anything. So we have set it up to allow you to code your own intervention, where the in type 1, for example, is set to -1. And when you set this to -1, it's expecting you to provide another macro that contains your code for the intervention. So the key thing that you have to be aware of is that this macro is going to get called within a loop over values of the time variable. So you're basically coding a rule where you're within that simulation step, and when it calls your macro, it's going to have just simulated the treatment and confounders at time k, and now you're going to say, how do I intervene? And that's really what you're going to code. This becomes more or less complicated depending on how complicated a function of the past that treatment rule depends on, because you basically have to keep track of that the function of the path. So we have a few ways that we've set up to try to make this easier. This is the way I chose to code this, and I realized the way I originally coded this, when I originally coded it, I was coding it for myself, not thinking I'd have to explain it to anyone else. And I realized the way I coded it was particularly complicated, and there was a way to code it much more simply. But I think that might only work for the case where m equals 0. So I haven't done this yet, this will be in the documentation when we upload the final version in April, but I will add how you can do this for general m, in other words, for a general grace period. But for now, just to keep it simple, I'll show you the code, the simple code that I was able to come up with for the case where there's no grace period, which definitely makes it easier. So I think this was yeah. So basically, the difference between this call and the other call is that before I define the interventions, I'm going to define my own macro above the definition of the interventions that defines my treatment rules. So I think I want to try to step through this with you. So actually, before I go through this code, I'll show you how this changed the definition of the intervention. So we go down here. Again, we have let interv 1 equals int no equals 1. We have a label. Now I've made the label one of my x cutoff interventions, start part and C for this one. I've defined x as 500. I made intervention 2, x equals 200. So I'm going to estimate the risk ratio comparing start very early versus start very late. And the key difference here is that I've added, well, first of all, my in type 1 is now -1, as opposed to one of the 1, 2, 3, or other options in table 3. And I've also added this int user macro 1, which is the name of the macro that contains my rule. And I'm allowed to, and I did this, I created a macro that has its own parameter corresponding to the value x. So I don't have to create several macros for every different value of x. I'm just going to use this one for each one, and I have this macro parameter called incut that I can just set to 500 here, and then I can set to 200 here. So that's how I decided to code it, but I could have had a separate macro for 500 and a separate macro for 200, and then I'd have to put the 200 macro name here. It's just whatever macro contains the rule for interv 1 or interv 2. Okay? So now we can go through the syntax just so you get a sense. So this is really just regular SAS programming. You don't have to code this with any macro variable. For example, I could have hard coded in here 500 or 200. I just decided to do this to make it a little cleaner. So again, this is going to be called within a loop between month equals 0, the first possible month, and time points minus 1 up to 59. So it's going to be calling this code each time iteratively. And again, this is happening right after the values of exposure and confounders at time k are simulated under no intervention. And then you're telling it, how am I going to intervene according to my rules? So the simulated values, so this was actually a change from version 2.0 to 3.0, which I think was a good change. The simulated values before intervention now have exactly the same names as they have in your data set. So they just are the simulated value at time k of ARP is just called ARP, and the simulated value of LNP4 is just called LNP4. The problem is that it's going to keep overwriting that value at each time. So you have to if you need to sort of keep track of complicated things in the past, then that creates a little bit of a problem. So the way that I decided to do that was I created a variable called DIMECON, which I made sure that it's basically a check of whether I've met the conditions to treat. So what was the condition to treat? is that my CD4 cell count has first got below. I first switch from 0 to 1 on this variable when I first meet the conditions to treat, which is either that my CD4 has first got below the cutoff inset, or I have a diagnosis of disease. So those are my conditions. So to sort of set up this loop, because I want to make sure that once this becomes one that stays one, I want to track a lag value of this as well, and I'm going to set after I change 1, so then on the next iteration, I can just check, was the last value 1? If so, I'm just setting this to 1. I don't care what's happening now with CD4 and age. Because, again, it doesn't matter if under this rule, all that matters is I initiate treatment and CD4 first got below CD4. If it goes back up later, that doesn't matter. You still have initiated treatment. I don't pay attention to what happens after you initiate treatment. So at month 0, you can think in the very first iteration of this loop, I'm just going to fix whether or not you met the condition of the path time to 0, and everybody's going to have that when the loop begins. Then I'm going to check if that if I didn't meet the condition on the last, if I met the condition on the last time, then set that I've met the condition at this time. Now, if it's month 0, by definition, that isn't met, so I'm going to skip this code if I'm in month 0. But if I'm in month 1, well, let's actually pretend we're still in month 0. So we're still in month 0, this doesn't get called because I set this to be 0 for month 0 by definition. This could get called in month 1 or 2 or after that. Okay, so then I'm going to end up, if it's month 0, I'm going to end up in this code because at month 0, CIMPOD lag 1 0. I'm going to check, do you meet the condition? In other words, if log of CD4 is less than the log of X, which is the same as if CD4 is less than X, or I have age, then I'm going to say I meet the condition, CIMPOD equals 1. Else, I don't meet it, and I'm going to set a new variable, CIMPOD underscore lag 1, to CIMPOD. So if this became 1, this gets overwritten as 1. So now I have a tracker for the next time. Okay, so now I have both CIMPOD and CIMPOD lag 1. If CIMPOD is 1, CIMPOD, actually no, there's no restriction on that at this point. So now I'm going to see I have my simulated value of R. There's a simulated value that's been simulated. Now I want to decide whether to intervene or not. So this is just to set up, allowing me to make a decision on whether to change treatment or not. So if my condition is not met and the simulated value of treatment is 1, I should not have R equals 1. It should be 0. So I'm going to set R to 0. And if the condition is met and the simulated value is 0, I'm doing the wrong thing too. So I'm going to set it to 1. Okay? Go a little bit lower. Okay, and that's really it. Let's forget about this for a second. So if you go back up again to the loop, so now you have a value of CIMPOD. Now you're going to get back up again. When you're at month 1, this is going to be called because you're not at 0 anymore. So now, if you got a 1 on that first time, this was set to 1. So it's going to say if you met the condition last time, you still need it. So this whole thing is going to be skipped, and I'm just going to go right here. But if you didn't need it, I'm going to check do you need it this time, and then I'm going to change treatment accordingly if it was simulated in the wrong way based on your value of CIMPOD. So this is how I chose to code it. I actually originally coded it in a very different way. There's probably an infinite number of ways to code this intervention, but the idea is that in this step, I need to be resetting ARC appropriately so that it's consistent with the rule. Yeah.
The whole idea is that you can actually set your treatment according to your intentional intervention. So why does the simulation part actually simulate part? You can just set.
Right, exactly. So there's a couple of reasons. So the main reason, in this case, in fact, it's the only reason we do it all the time is to get those natural course versus observed plots, because that is going to depend on the simulated value of treatment, or in other words, a model for the observed value of treatment. So that's for a model specification. And here, I know what you're saying. Basically, I realized the way I coded this, I could have been much simpler. The reason is that we also have, I mentioned before, remember we had that part of the output that said % intervened on. I actually put that out to not confuse you, but I realized I should have just changed the way I coded it. We also have some other stuff underneath here, which is a tracker. If this gets called, I'm going to track that a change was made because you simulated the wrong value. But I mean, if that's not important to you, you can just completely ignore that part of the output. And I don't really know, honestly, why it was important. I mean, it actually could be, it really just gives you a loose sense of, like, how far off is, according to my model, how far off is this intervention from what people are actually doing in the data. But I don't really tend to look at that output myself, as other people might. So yeah, we could just completely just say if n times equals 0 or equals 0. Yeah, you could just ignore what people are doing. I'm just saying this because if r is equal to 0, I don't need to do anything, but in fact, I get exactly the same answer if I just ignore this entirely and just that part to 0 at that point. So that's a really good question. The other reason we might have a model for R, and we could still ignore this and code. Is again, if we had that grace period, we would be simulating ARC and holding on to that simulated value during the grace period. You wouldn't touch you during the grace period. You're allowed to do whatever you want during the grace period. So, but in terms of, if your question is about why you have this and this, that makes sense. You don't need it unless I had added back these trackers of your invention, and that will be in the documentation and example of how the syntax for adding those trackers back in. So, and then just the last thing here. So this last part, I set, so in each month loop, there is internally an array called sart that is basically holding, so remember we had the mean min max of sart1 through sart60. It's holding that. So if you don't assign this to that array, that output is also going to not be correct. So this is just, again, a way to make sure that the output, but this is not used in the computation of the risks, or, so this shouldn't affect your estimate. So this is sort of what we've come up with, and if there was an easier, more user-friendly way to do this, it would be great, but in fact, this is the way we've been able to figure out how to be more flexible about this. And the way we sort of tend to do this in practice is we share, people have updated this code for other dynamic interventions, and really this could be a general way, you could just put that condition, change the condition for another, here the condition was if LMC for less than log in cut and age, then you've got the dynamic condition. But if there was you had another data set with other variable names and another condition, I can imagine you could fairly easily adapt that for a dynamic condition. So that is the user-defined interventions. I think I went through this. So then again, I just call that macro with different values of input. And yeah, so I just talked about all this. So in the case of the grace period, the code would be a little more complicated, and we can put an example of that in the documentation. So another exercise you could try is you could take that HIV call to.fast and add a third strategy with a new cutoff, x equals 350, and just remember to change the numbing parameter in the main T formula macro. Now if you have 3 interventions, you need to change that from 2 to 3 so that it will run for all 3. So do people want to take time to do that on their own, or should we just, I don't actually have too much more, so I think I'll be able to get through all of it. Or just have time for questions. Who wants to take time to work through that exercise? Okay, so let's move on. You have access to all these files, and the solution I put in HIV exercise 2.sap, so you can totally do that on your own. So the last part is about this issue of the visit process and what kind of parameters there are to incorporate that. So again, with HIV causal, we've done a lot of analyses with HIV causal, and we sort of created these options to deal with that particular data set, but it's relevant really for any so-called clinical cohort where subjects are measured at random time. So in the example yesterday with the nurses' health study, we had a fixed measurement process. We call this an interval cohort because basically we had measurements for everyone every 2 years. There's no variation in when we get to update their covariates. So in this case, the visit process itself can be a time-varying confounder because people who come in more frequently or haven't been there for a long time may be different than people who were more recently there in terms of their risk factors for disease. There's a nice paper it's referenced in the documentation by Anand et al. 2008 that talks about this actually in the context of the IPW estimator. But again, that's the only difference there is our parametric model. That the confounding assumptions and principles are exactly the same. Here we have in the data set covariates visit _CD4 and visit _RNA as indicators of whether the time-varying covariates ln-CD4 and ln-RNA are current measurements, respectively. So we could think, just from what we've learned so far, well, these are time-varying covariates. How do we incorporate these into the macro? We could just add a code 5 visit CD4 and a code 6 visit RNA and model them, right? I mean, that would sort of be an intuitive thing to do. But the reason that that's not the best thing to do is that this would not maximize basically a priori knowledge we have about deterministic relationships between these variables. So we can do a better job in terms of model specification by incorporating knowledge that we have about these variables. And we really have 2 pieces of knowledge. One is that we know by definition that if visit CD4 is 0, then ln CD4 is equal to its last value. That's what visit CD4 equals 0 means. And we also know by our definition of a censoring event, the fact that we don't allow people to go for an infinite amount of time without a visit, we may have to cut off 12 visits, that the max sum of either visit indicator is 12. We know this to be true. So we don't want to arbitrarily, so in this case, we have automated options for basically both modeling and simulating the data that account for this. In particular, I'm not sure if I actually say this, but the way we account for it is the fact that when we fit models for LNCD4, we restrict these to those with a visit CD4 equal to 1, because those are the only records where there's a probability associated with what the value of CD4 is. For the case where visit CD4 equals 0, we deterministically know what the density is given the past, and probability 1 is equal to the last value, so that there's no need to throw a parametric model on the whole on every history and over-extrapolate. It keeps us basically from over-extrapolating. And then in the simulation, if we simulate a value of visit CD4 that's 0, we're not gonna simulate CD4 from a model. We're just gonna carry forward also in the simulated data set, so that aspect of the observed data is mirrored in the simulated data. And finally, we're going to restrict our modeling process to records where the sum of the visits is, I'm actually, in the moment, I'm forgetting exactly how we do this, so I'm actually not going to say how we do it, but we're restricting further on a function of the sum of the visits. And when we simulate, if we simulate, basically we simulate such that we can never simulate a visit indicator that's 0 after you've had 11 consecutive zeros. So, because in the data, people are censored after they have 11 consecutive zeros. So we're never going to see more than 11 consecutive zeros. So it matches, we're making it so it matches that feature of the observed data as well. Again, trying to avoid over-extrapolation. So this is basically, we have some other parameters that you can add to covariates like LNCD4, like LNRNA, that have a visit process. In other words, visit indicators marking whether they're current or not current measurements. So in this case, you can also add the covariate, define the macro parameter code X random visit P, a little bit long there, which is where you set what the visit indicator is for that variable. So for LNCD4, if COVAX is LNCD4, we define COVAX random visit P as the visit indicator for LNCD4. And then we also allow, in this case, if you choose, like we did, to censor, you don't allow an arbitrary amount of time without a visit, you can set this time where you would censor. So in our case, we set it to 12. This is COVAX visit P next gap. Some of these names are a little bit cumbersome. And then we have this other variable, which is really needed for for doing some of these internal restrictions. This is COVAX visit P count. This is a variable that you would include in your, the name of a variable that should be included in your input data set. That's the time since the last measurement of that variable at the last time, at the lagged value. So if you're on, say, month equals 3, it would be the sum, the sum of the times where you had consecutive zeros to the time before. So this is all in the documentation as well. And analogous in our call, there would be, you can add analogous syntax for RNA because that also has a random visit process associated with it. So the last exercise I set up was, if you want, you can incorporate that assumption into the call. I basically gave you the code on the last slide for LNCD4, so you could do the same thing for LNRNA. And I think that's everything. So if you guys want to spend time, playing around with the code, if you have questions or you have more sort of theoretical questions or any kind of questions, we have another 20 minutes, I think. I'm happy to answer anything. Or you're free to go. Yeah. Well, so it depends. So generally, we don't think in the structure of outcomes happening at multiple times. We can only think of it that way when the outcome is a failure indicator. But if it was just a measurement like CD4 cell count, right? You could think of that as an outcome if you were interested in the effect of strategies on CD4 cell count. But in this context, you have to fix the time that you're interested in. So you could certainly repeat this algorithm for several times, but this is not like a mixed model or something where a repeated measures model, right? We're not fitting a model for the outcome measured at several times and making a claim that we're thinking of the outcome at a particular period of time, at a particular point in time, like an end of follow-up time. The exception again is only when we think about cumulative risk in the case of a failure time indicator. The event you're because the outcome is really in that case failure by 5 years. So in that case, if you failed at 3 years, you're counting as a failure by 5 years as well. But so in that case, for CD4, you could certainly that you pick a different outcome type. So that would be the EOSU outcome type. And the way the macro is set up now. Everything would really be the same. The only difference is that it only uses, you would definitely, the censoring indicator setup would be exactly the same, and you would code the outcome as missing if you're censored. In that case, though, you would be adding CD4, say, at 5 years as your OUTC variable, the outcome variable. And the way it's set up, because we have a person time data set, it's like everything up until that last, say, month equals 59, it can be garbage. It's not used in the month. You can leave it empty. Yeah, it can be anything. But you can still include CD4 as a time varying covariate because all the CD4 counts up to that time are time varying confounders for that effect on marginal mean, population mean CD4 at that fixed end of follow-up. So. Any other questions? Okay, yeah. So that's really important. So basically, I don't have the G formula on here, but so as we said, the G formula we can think of as this weighted average thing, right? Where we have these, before we start talking about any models, we can just think of this, we can almost think of it as a parameter in itself, like there's a population value of this function, right? That if you had no sampling variation, we could potentially say our statistical goal is to, our estimand is this function, the G formula. It's a meaningless function unless we could make the assumption of no unmeasured confounding, and then it's equal to this counterfactual mean. But we can actually think of it as a parameter in itself that we're targeting. And so the difference between, say, ICW and what we just talked about here are just different ways of estimating that target, that parameter in high dimensions when we have where we have too many histories to be able to enumerate them and compute this weighted average by a contingency table. So the way that this works is that this G formula, the weighted average, it can be rewritten as a function of inverse probability weighted means. So in the case of dynamic strategies, those denominators of those weights are the probability of continuing, adhering to the intervention G at a given time, given you that here up to that time and the rest of your path. So it's actually algebraically the same as that weighted average target, the G formula. But when you represent it that way, it sort of makes clear that you could estimate this quantity by just estimating the denominator of those weights and taking a weighted mean. Let's say in the simple case of where it's just mean CD4 cell count, it's simpler to describe at whatever time, you just weight that mean of that CD4 cell count. Where marginal structural models come in is, so in principle you think, well, I'm just interested in comparing, here we considered x equals 500 and x equals 200, so I could just do two separate weighted means where one is adhering to the weights are for adhering to strategy x equals 500, and then I construct a separate one weighted by inverse probability of adhering to x equals 200, and just takes the difference. But the problem you potentially run into there is, again, an issue of, do you have data to support the question? What if you have a data set with tons of, 100,000 observations and only 10% are adhering to those two strategies? So you can choose to be really true to your data and just do that, what I just said, or you can impose a marginal structural model as a function of x. And then you can use basically everybody, because everybody is adhering, or at least the way that, so this is exactly what's done in Warren Kane's 2010 paper. They basically fit a model where they define x as 200, 250, 300, 350, 400, 450, and so on, a lot of different values of x. And then effectively what you're doing when you fit, so this is an example of a dynamic marginal structural model. And you're basically, the way I think about it, you're fitting a model on the G formula itself as a function of x. That's the data. That's the statistical thing you're doing. Forget about counterfactual, because that's a DAG issue, that's a conceptual thing. But what you're actually doing when you say, is the marginal structural model correctly specified, you're actually fitting a model to this weighted average as a function of G, or in this case x, the cutoff. So the way you operationalize that is, to get the details, you should sit in on that workshop or read the paper, but effectively you create a bunch of artificially censored versions of your data set. One you artificially censor as soon as you stop following x equals 200, another 250, another 300, and so on, and you stack them. And then you have an indicator of which data set is this from, an x value is from 200, and then you're going to basically fit your marginal structural model to that stacked artificially censored data set. So that's a way to think about dynamic marginal. That's a way to think about the equivalence more generally. The way we usually think about marginal structural models is in the context of only static strategies, and in that case, because everybody is following some static strategy, that's why you can just view that as a weighted regression. It just turns out that if you make your question about all possible static strategies, so in this case, all possible static strategies will just be all possible combinations of all possible ways initiate at time 1, initiate at time 2, initiate at time 3, initiate at time 4, all the way up to time 60. In that case, if you weight that mean by the inverse probability of receiving the treatment you actually receive, and you make that G formula just a function of the time varying indicators initiating, that turns out in the absence of models, in other words, that marginal structural model was completely saturated. You put in all possible main terms and interaction terms for all treatment times, and your weight denominators were also completely saturated models for the probability of receiving the treatment you actually received. it would be equivalent to that weighted average for any choice of static intervention that I assign. So the relationship is that these are equivalent approaches for when implemented for the same strategies. And there's everywhere you have to impose models, the models perfectly fit the data, which will be the case where your models are allowed to be completely saturated. So when you have few time points, all of your variables are like binary, let's say. You could show yourself that I run this program for always treat, never treat, and I get an estimate of always treat versus never treat out of a standard IPW analysis with, standard marginal structural models. You'll get exactly the same answer if the marginal structural model is a saturated marginal structural model. And same for double or less targeted maximum likelihood estimator. Same. So the same strategies, same data, same assumptions, same assumed confounders. And everywhere you have to put models, you put completely saturated models, exactly the same. It's the fact that you never can do that though in practice, which is where all of these methods come from. Okay, I think you can officially stop, but I can hang around if you have any individual questions. Feel free to come ask me.